Hi, Marco Mennuni and Mike Gibson coming to you live from ACC 2025. We're talking about something near and dear to my heart, anticoagulation after AMI in those patients who had a lot of clot in their artery, large thrombus burden. Talking to us about the ARISE-ARMYDA T trial. So talk to us a little bit about what you did and what you found.
So thanks for having me. Let's start with our research. We focus on a big challenge in treating heart attacks, specifically STEMI patient. We have a large coronary thrombus burden. So we know these large clots can complicate treatment in terms of embolization, no reflow, and worsen clinical outcomes. So when we treat this patient, we use a combination of pharmacological, mechanical strategy, heparin, intracoronary fibrinolysis, thrombus aspiration with the first stenting, everything to prevent thrombus-related complication. However, the evidence supporting this different pharmacological strategy remains weak. So here is the idea was to test whether adding a low dose, a very low dose of rivaroxaban, 2.5 twice a daily, a direct factor 10A inhibitors could help reduce the thrombus burden before placing a stent. So we ran the ARISE-ARMYDA 7 trial, which is a randomized, controlled, open-label pilot study. And here is the basic setup. So we enroll 40 STEMI patients with a large thrombus burden. We perform the initial PCI to restore blood flow, meaning at least TIMI2 flow. Then we delay the stent placement and we randomize patients into two groups. The first was the interventional group receiving low dose rivaroxaban, 2.5 milligram twice daily on top of DAPT, aspirin and ticagrelor. And the second group was the control group receiving only DAPT, aspirin and ticagrelor. So how did we measure the reduction in thrombus burden? We use optical coherence tomography, a very precise imaging technique to measure the thrombocytes at the baseline and after 7 days of treatment. We use as a metric, we use the Thrombus score. Thrombus score is a way to measure how much of the blood vessels blocked by a clot based on how many sections of the artery affect. So we calculate by dividing the coronary artery cross-section in 4 quadrants and counting how many of them contain thrombus along the length of the vessel affected. And this was the primary goal, was to compare the reduction in thrombus score between the two groups. So what we found, the results were quite promising. I mean, compared to DAPT alone, adding rivaroxaban significantly reduced the thrombus burden. And here are some findings. So there was a reduction in thrombus score. The thrombus score after 7 days was significantly lower in the rivaroxaban arm, 39 versus 82. And if you look at the relative reduction of thrombus score versus baseline after 7 days versus baseline, this was greater in rivaroxaban use with 61 versus 36% in the control group. So, and then we have several other metrics by OCT like thrombus volume, thrombus area, thrombus length, and all these metrics were consistently reduced in the rivaroxaban group. And then we have some important information in terms of safety, because there were no major safety concern. We saw no significant increase in major bleeding, together with a substantial safety of deferred stenting, with no difference in MACE, no difference in death, MI, stroke, TVR between groups.
Oh, very provocative, reducing thrombus burden over those days. Of course, when I did the Atlas study, we found a reduction in death and my stroke with that low dose. We also found about a 31% reduction in stent thrombosis. We often think of stent thrombosis as a platelet problem, but the antiplatelets we have, aspirin and ticagrelor that you mentioned, they do not prevent thrombus activated clot. So they block ADP, but they don't block thrombin as an agonist. So very, very provocative. Are you going to follow this up with a bigger study?
That's the willing. So I mean, our study suggests that adding low dose of rivaroxaban could be useful in early phase treatment strategies. This could be a different compared to Atlas. So we give rivaroxaban right away in the cath lab. So with this action, we try to maximize the effect of anticoagulation in the early and fresh thrombus.
Yes,
So
very
this
early
the,
on.
the dual pathway inhibition approach could be much more effective in early phase. This is what we believe, and of course we need to say this is a pilot study, meaning we need a larger multi-center trial to confirm. Of course, we need to translate if there is a translation in terms of clinical outcomes, and for this we need to design and run a bigger clinical trial.
Well, Marco, thank you for sharing with us. Very interesting results. And thanks to all of you for joining us here live from ACC 2025.
Thanks for having me. It was a great talking about our work. Thank you.
Excellent. Thanks, Marco.